Hi, my name's Molly. I'm a nursing PhD student and I work as a staff nurse in the emergency department.
I'm Dan. I'm an undergraduate at Penn studying politics and government, and I'm Penn student body president.
I'm Kayla. I'm a second-year student in the School of Social Policy and Practice, getting my MSW. Hey. And I work as an inpatient case manager in a psychiatric hospital.
And my name is Meghan O'Brien. I'm a medical student, fourth year at the University of Pennsylvania, and I'm also getting my master's in bioethics. And we are Team reMind. So thanks for hanging in there also through this day. So our idea for this challenge grew out of our collective experience in healthcare and health policy. Specifically, we're interested in the impact that no-shows have on patients, their doctors, and the communities. In particular, we're interested in the impact no-shows have on the vulnerable population of the mentally ill, for whom gaps in continuity of care are particularly deleterious. So in order to address this important problem, we decided to think big and start small with a micro-intervention of a text message reminder system that will help patients who have recently been in inpatient psychiatric stays get to their first outpatient appointment. Our thought was, and the research suggests, that this will improve patient care, eliminate systemic waste on the order of millions of dollars, and generate an important data collection tool that will inform future interventions, or a cascading intervention, as we like to call it. We call our intervention reMind. So what's the problem? Well, in Philadelphia, over 11,000 patients are discharged each year from acute inpatient psychiatric stay. The standard of care is to ensure that these patients receive continued care in the outpatient setting by setting them up with an outpatient appointment in advance of their being discharged from the hospital. However, the problem is that on average, 42% of these initial appointments are missed. Research suggests that the single most common reason for patients not showing up at these appointments is that they forget. And as you might imagine, with serious mental illness, maintaining treatment is a critical factor in recovery. Patients who miss their initial appointment are more likely to fall off of their medication and treatment plans and are up to 50% more likely to drop out of treatment altogether. And while 90% of patients who make it to that initial post-hospitalization appointment will stay out of the hospital for the next year, 25% of those who miss that appointment will end up back in the hospital within 12 months. In Philadelphia, those rates are even higher. So as you can see, helping patients get to that initial post-hospitalization appointment is a critical first step in promoting care continuity. Part of the problem is that outpatient providers don't take responsibility for these patients until they actually show up at their door, leaving patients vulnerable to falling through the cracks. Well, why do we care? Well, no-shows affect patients. When the mentally ill drop out of care, they're more likely to suffer homelessness, unemployment, and becoming a risk to themselves or to others. No-shows affect outpatient providers. As one of our endorsers described, outpatient providers are losing their shirts due to the lost revenue from no-shows. In addition, they also suffer longer wait times to next available appointment that they're able to offer patients who are already in treatment. No-shows affect hospitals. As we increasingly move to a pay-for-performance model, hospital grades are tied to readmission rates, which in turn are tied to reimbursement. In addition, many hospitals are overcrowded. And lastly, and importantly, no-shows affect communities. When the mentally ill drop out of treatment, they're more likely to face a mental health crisis and require the use of community resources like police and emergency services. In addition, the mentally ill are disproportionately represented in the prison system. And so when the mentally ill decompensate, they're more likely to land in the expensive prison system. And lastly, since Medicaid is the single largest insurer of the mentally ill, preventable re-hospitalizations represents a significant drain on public funds. In Philadelphia, the cost of re-hospitalization for those psychiatric patients who have missed their initial outpatient appointment is roughly $9.5 million a year. In light of recent budget cuts, now more than ever, we need to better utilize the existing resources that we have so fewer patients fall through the cracks. So we decided to think big and start small with a micro-intervention that will hopefully trigger a cascade of future interventions. Our idea is, we think, elegant in its simplicity. We want to use reminders, primarily text messages, as a cost-effective way to get patients to keep their initial outpatient appointment after they've been discharged from the hospitals. Our service will exist as a website called remindphilly.org that will be available to hospital discharge planners. It will take users a maximum of 5 minutes to log on to this password-protected and HIPAA-compliant website and enter the necessary patient and appointment information. The website will then generate 2 text messages in advance of the patient appointment to help remind them to get there. In addition, it will also generate 2 phone call attempts and an email, as well as a handout to be given to the patient at the time of discharge so they have a hard copy of the appointment information and directions how to get there. And since our collective experience tells us that family members and friends are often involved in the care for the mentally ill, we have made it so that collateral contacts can receive some reminders as well to help remind the patients to get to their appointment. Our idea didn't come out of thin air. In fact, it's very solidly based in the research. In 2012, a British pilot study looked at 4 inpatient psychiatric hospitals and using text messages as a way to get their patients to their outpatient appointments. Authors found that the text message reminders reduced no-shows at a rate of 27%. When you translate this on the national level, annually this results in a savings of $245 million in England. Additionally, in 2008, Kaiser Health Systems in California, known for its cost-effective innovations, ran a 1-month text message-based reminder pilot. And in this one clinic, in 1 month alone, they were able to save $275,000. Their CIO was impressed enough to greenlight the program as an upcoming national initiative. We were similarly impressed. So in order to implement reMind, we thought it best to follow the money. For mental health care in Philadelphia, the money starts at the state level, trickles down to the city level, and the city of Philadelphia contracts the Department of Community and Behavioral Health, which is a nonprofit organization that is charged with administering mental health care to Philadelphia's 420,000 Medicaid recipients. The vast majority of Philadelphia's mentally ill have Medicaid as their insurer. And while there are many, as part of our policy of thinking big and starting small, we decided to hone in on the bottom 2 rungs of this financial ladder. So on community and behavioral health, which will be charged with implementing reMind, and the outpatient providers who accept CBH as their insurer. And while there are many stakeholders within this paradigm, we thought we'd go straight to the top. So we met with Dr. Matthew Herford, the Chief Medical Officer at CBH, and pitched him our idea. He called reMind a no-brainer, and here's why. First, reMind is the first step in a series of cascading interventions. It will reduce no-shows, reduce readmissions, and improve patient care. Importantly, it will liberate the money saved for reinvestment into psychiatric improvements that will benefit all of Philadelphia's mentally ill, including those for whom a text message reminder system may not be appropriate or effective. Secondly, reMind represents an important data collection service. Currently, CBH keeps track of which patients show up at outpatient providers by keeping tabs on their Medicaid payments rendered. However, CBH doesn't know if patients who are not connected to outpatient providers are not being made appointments or are not showing up for the appointments that were made. By keeping track of appointments made, reMind will fill in this important data gap that will inform future interventions targeted at those who are most vulnerable. While Matthew Herford called reMind a no-brainer, what's most exciting is that he said that he could carve out space in his budget for its implementation and maintenance costs, which you can see here are quite modest. We've also made many other important partnerships. Just this week, we've had 2 key endorsements from senior executives at the Department of Disability, Behavioral Health and Intellectual Disability Services, And while these 3 buy-ins collectively mean that reMind is shovel-ready, we also realize that we have to appeal to those who will be on the ground using the service. We have made many inroads in this department with hospital discharge planners, hospitals, and outpatient providers. However, for full implementation, we'll launch a simple educational campaign. As you can see from our timeline, by December, we hope to have the reMind service up and running, collecting data and connecting patients to their outpatient appointments. If you think that the reMind service seems obvious, you are right. However, a text message reminder system doesn't currently exist because healthcare traditionally lags behind the IT curve, and there's tremendous limitations on existing personnel. In addition, until the Affordable Care Act has made reducing readmissions a priority, there hasn't been a push to reduce them at quite the same level as there is now. So our thought was that by taking the responsibility for implementation and maintenance of this reminder system out of the individual hospitals and placing it at the central level, at the city level, in the hands of CBH will eliminate an important barrier that will allow hospitals to access this service for the first time. We also thought that this model could be recreated in other realms of healthcare and across the nation, hallmarking Philadelphia as a national leader and innovator. If reMind helps just 3 patients stay in treatment and out of the hospital, it will have recouped its implementation and maintenance costs. If Philadelphia sees a reduction in no-show rates similar to that of the British pilot study that serves as its model, that will translate into annual savings for Philadelphia of $2.5 million. That's an 8,000 annual rate of return on the annual investment. Importantly, it will generate data that will inform future interventions, so we hope that it'll be like the gift that keeps on giving. And perhaps most exciting for us, will improve patient care. And I probably don't need to remind you at this point that that translates into a better Philadelphia for us all.
Secondly, let me piggyback. I heard you say you would like for CBH to handle it. Why do you want CBH to handle it and not have something outside handle it?
Two great questions, and I really appreciate your first question because you always know you're going in the right direction when somebody says, "Why aren't you doing this already?" So it's nice to hear it. Our opinion is the reason that this hasn't been innovated yet is because there is no point in this system between Medicaid or CBH and the providers, whether outpatient or inpatient care providers, that is looking for innovations in care for transition. Hospitals are looking at ways to innovate within hospitals. Outpatient providers want to innovate outpatient providers. But this idea of transitionary care, although it's being incentivized, there's nobody really thinking about it in a big way. So that leaves sort of a gap for people like us to come in and think and bring up these ideas. And we do think that the data speaks for itself. And obviously, Dr. Herford agreed. A lot of other people in the department have agreed, which is why it's moving forward. And your second question was why CBH?
Yeah, why CBH? Why? Because it sounds like
this is an old version. Oh. Right. Sorry, we have an old version of the power of this thing up. So the why CBH as opposed to say the hospitals or an outside organization. We actually, the truth is that in our conversations we had people suggest that we should drop out of the challenge and we should like make this a business and go and peddle our wares. Right. So please nobody do that. Or outside Philadelphia, you're welcome to. The reason that we approach CBH from our perspective is that it's the most long-term source of funding. It's the most stable source of funding for this project, although this is a pretty modest amount of money for a nearly $1 billion organization. For any individual hospital or outpatient provider to take on these costs would be pretty significant for them. So we think that this is a pretty sustainable source of funding. In addition, it has the benefit to CBH that it doesn't really have to anybody else, which is it informs what they call their pay-for-performance metric, meaning they give hospitals and outpatient providers a grade on things like their rehospitalization rate. And this will provide a set of data that they can also start to look at hospitals and incentivize them to improve their standards of care.
So they're willing, what I heard you say, which is the first time I actually heard someone say, that he's willing to carve out his budget.
Yes.
He's willing to carve something out of his budget.
We didn't get that in writing.
What they said is they have.
I was impressed.
So were we. We do have a bill. We were able.
Are you familiar with something called social innovation bonds?
No.
No.
That's what I would suggest to you in New Jersey. Social impact bonds. In Massachusetts and New York are two states that have passed these laws. And it seems like a concept that would be in that particular area. In fact, I've been to see legislation on this right now. So I'm looking at a way of marrying a particular service. So these social impact bonds, innovation bonds, innovation impact, right?
Social impact. Okay. Maybe we'll ask you about it afterwards. Sounds interesting.
Just a quick question. Is having reliable contact information a challenge with the population at your university?
Thank you for asking that. That's been something that's been brought up a lot when we've talked to different stakeholders and pretty much everyone. And while the mental health population is certainly a unique population, faces high rates of homelessness, unemployment, poverty, a study in 2010, which we had a slide which we don't have now, in Philadelphia showed that among the homeless population, not mental health, just the homeless population, nearly 50% have cell phones. That doesn't mean everyone is willing to be texted, but we find that to be a good start. And there's really not much reliable information on exactly how many people in this population have cell phones. but certainly all the mentally ill aren't homeless, so should be higher than that. So.
And then in addition, regarding the cell phones, there's been a program that's colloquially called Obama phones, although it was actually started under Clinton, continued under Bush, and now under Obama, that connects patients with who are below a certain level of income to a free cell phone that has 250 minutes a month. And so while we recognize that we can't reach every patient and that the text message reminder may not be appropriate for all the mentally ill, our thought was to go for the low-hanging fruit and use the money that we save for investments into psychiatric care that will ultimately serve all of the mentally ill, improvements for all of the mentally ill. So that was our thought. We don't maintain that we can reach everyone, but we want to reach who we can.
Like all the others who have heard impressive project here. Can you just go back on the numbers for me? How many patients are we talking about in Philadelphia? What were the numbers that you said?
Yeah, unfortunately, this is an old version, but we had like a whole, you'll just have to imagine this whole beautiful slide exactly answering your summary. Oh yeah, you could look at it in the summary as well. But
So the way we get the numbers is about 11,500 people go to the hospital every year for mental illness. They're treated inpatient, they spend a night maybe, and then they're discharged, 11,500 of those people. Nationally, 42% miss their appointment. The number one reason, forgetting. Number 2 and 3 reasons are things like just having to cancel or reschedule, which fortunately are also solved by reMind, because in the text service, we're going to provide them, here's the number to call if you need to reschedule, here's information about location, etc. The way we calculate then the numbers of savings is 1 in 4 of those people who miss their initial outpatient appointment aren't going to keep going, and they're going to end up back in the hospital. In Philadelphia, the rate's a little higher. It's actually closer to 30%. That then, when they're back in the hospital, it's an average night stay of $1,400. Total cost for all of those Philadelphia residents that end up back in the hospital is about $10 million. $9.5 million is our conservative estimate using those national numbers that are a little lower. We think, based on the British pilot study, that we can help immediately about a quarter of those, 27%, or 2.5 million.
We actually addressed a lot of the resistance in our initial planning stages. I think we were later to come up with an idea than a lot of the teams because we spent a lot of time thinking about this problem and really engaging with the stakeholders and the people on the ground. So the initial thought that we would have, that we did have, was that we don't want to put an unnecessary burden on people who work in inpatient psych hospitals, who already are overburdened and underpaid. Not that I have strong opinions on this matter, but this is really something that's meant to sort of capitalize on the time investment that discharge planners are already making. You already spend, I already spend so many hours trying to make phone calls and find people an appointment and find them a doctor that they like in a place that's close by and in some place that'll take their insurance, and then to have them just not show up is really a big letdown. So this is our big sell is sort of like invest another 5 minutes and all of that time will have been worth it. So that was sort of one thing, and then you had another one.
Yeah. And one of the other initial points of pushback was, why should CBH fund it? And really, when we met with Dr. Trevor Hadley, who's a professor here in the School of Medicine, he said, well, why don't you collect data? And why don't you sell it to CBH, as now you're going to have data on who has cell phones? And that's even a very valuable thing. Why don't people come to their appointments? Is it the provider's fault? Well, not fault, but is it impacted by the provider, by the hospital, or by the patient? So when we pitched it that way to CBH, they seemed to think that, combined with the fact that it was not a large amount of money, that it was a good idea.
It's hard to say like what percentage. There's been data on this sort of on this problem basically since about 1993, and the data basically indicates that that forgetting is the single largest cause, but it doesn't give a percentage of like 15% forget, 10% decompensate and end up back in the hospital before their appointment. It doesn't break down quite so simply. So we can infer a little bit, if you'll infer with me, and if it's the number one reason, and if, according to this British study, just sending people a reminder improved attendance rates at that initial appointment by 27%. So then you could say that probably about a quarter of the people are just forgetting their appointment.
I just had a couple questions about the vendors that you use to do testing. I read a little bit about the Kreider lesson learned. So I'm just wondering what you guys thought of these things. Like, these are mental patients, so what is the text that they're told us? I just want to see you in the podcast. Pays for the cost of the test, and then also I saw that they had a challenge with their first evidence with marketing messages.
Yeah, so that study is actually, I should just give a little bit of clarification because I know we had to kind of zoom through it. It wasn't with a psych population. Okay. It was just in a general clinic. The reason that we wanted to highlight it is because, as Meghan so very eloquently highlighted, it's an organization that's really renowned for its cost-effective innovations. So they tried this in one of their general clinics for a 1-month trial, and they were so impressed they decided to not continue with the trials and simply to implement nationally. So we feel like in a psych population, this would be even more important. As far as you can actually look in the back, I mean, not everyone, sorry, but you can look in the back of your proposal, and we do have mock-ups of the text messages, and we've been sensitive to things like the number of character limits, sensitive to things like you don't want to use too many explanation points or all in caps locks or anything like that, and also including things like contact information if you want to reschedule, and trying to make them as user-friendly as possible. And no, there will be no marketing.